they've all been really good, so we're all expecting the rest of you to be gooder, okay?
Pressure's on now.
Okay, this is Lawson, right?
Yep,
Parker.
I'm Lawson Parker. Kind of a Ricky Bobby situation with the name, but I'm a PGY1 at the Corwell Taylor program. I'm talking about just a brief overview of current refractive surgery techniques. At least for me, when I matched ophthalmology, pretty much everyone, when they'd hear that, oh, I'm going to be an ophthalmologist, they'd say, oh, so you're going to do LASIK, right? And so for those who haven't maybe learned about LASIK, for the medical students, just a kind of a little bit of depth into different types of refractive procedures. Do we have this? Perfect. So you can kind of split refractive surgery in a couple of ways. The best way is to look at it as an intraocular procedure or a corneal procedure. When you're doing intraocular, there's pseudophakic procedures where you're actually removing the natural lens of the eye, refractive lens exchange, which you're doing prior to a cataract forming, or a premium cataract surgery. And the other pathway is a phakic IOL, which is normally an ICL, an implantable Collamer lens. On the corneal side, there's a couple of different things you can do. Some of these are no longer in practice, and if you are getting told to do a radial keratectomy, maybe you should go see it someone else. But there's incisional procedures. Today, most common is a limbal relaxing incisions, which are done during cataract surgery normally to help release some of the astigmatism. There's laser procedures. Those are involving a lot of your more common refractive techniques that you hear about, PRK, LASIK, SMILE, and then a variety of other techniques that are performed for specific reasons. And we're not going to dive too deep into those. We're going to focus on just a few because time is limited. So we'll talk about ICLs, a little bit about PRK, LASIK, and SMILE. So if you were at Dr. Williamson's lecture yesterday with the panel, you kind of heard them go through different cases and see what each would do. Refractive surgery is very much like a toolbox, and it's important to be able to use all the tools to help your patient, right, get to the goal of not depending on glasses or contacts, which is what they want. That's what they're paying for. So ICL is something that not a lot of people do. However, it is a great tool to have because it allows you to help more people. So an ICL is a posterior chamber IOL. If you can see in the image, it's going behind the iris in front of the natural lens, made up of Collamer, hence the implantable Collamer lens. Indications, really this is a lens, so these are some of the FDA numbers that are approved from -3 to -15. And then it also can take care of some of the astigmatism, but in practice, a lot of people use it actually just to help reduce large amounts of myopia, and then to combine this with a corneal procedure to get the patient to plano. So that's another option, another part of the toolbox. There's some lenses that are now developing into hyperopic lenses for people with hyperopia. Outside of the US, there's more progressive uses of ICLs that you can see, and obviously the US kind of lags behind as we go through the FDA process. Some contraindications are a shallow anterior chamber or like a narrow angle on gonio. One of the worries with ICL is pupillary block, so anything that can predispose you to that, you're not going to do that. Advantages, you're able to treat a greater range of the myopia without removing any corneal tissue or removing the natural lens, which takes away some of your capabilities to do further procedures in the future. So Dr. Williamson said it best, that this is something that's reversible. This is something you can pull out. Once you ablate cornea, once you pull out the natural lens, you're kind of stuck. Disadvantage, there's a risk of cataract formation, risk of pupillary block, and obviously it's an intraocular procedure, so with any intraocular surgery, there's risk of infection, bleed, all of that. PRK. I'm a big fan of PRK. I had PRK done. Changed my quality of vision. It was great. So this is the first of its kind to use a laser instead of a blade to remove corneal tissue. Indications are to kind of treat a mild to moderate myopia, hyperopia, and astigmatism. The reason why it's not severe myopia is because you are ablating corneal tissue. So when you're performing any sort of laser on the cornea, you have to take into account corneal thickness and how much residual cornea you'll have after the ablation. For me, I was like a -6, and so I was kind of borderline. But, I was able to have PRK, and we'll kind of talk about why I did that instead of LASIK. Contraindications: uncontrolled dry eye, blepharitis, glaucoma, corneal ectasias like keratoconus, keratitis. A lot of these are controllable, so, different refractive surgeons will look at these as more relative versus absolute, as long as they can control the predisposing disease. And then advantages is you can use this to treat a thinner cornea. With LASIK, you're creating a flap, so you're actually taking some of the structural integrity away from the cornea and then doing the ablation, placing the flap back. For a thinner cornea, you don't want to lose that extra corneal tissue. So instead, with a PRK, you're just removing the top layer, the epithelium, and ablating directly onto the top of the stroma, which saves you some of that structural integrity, and the epithelium grows back. The disadvantage of that is the recovery time. To get back to the desired visual acuity, it's normally a 3 to 4 week process. The first week is normally painful, a lot of dry eye. You need to keep up on artificial tears. There's a risk of developing corneal haze and a risk of ectasia if you go too thin on the cornea. So this is LASIK, slightly different than PRK. Like I stated, you create a flap of the corneal tissue, you lift the flap up, you perform the laser treatment to ablate the cornea in the desired pattern. Similar to PRK, it's treating mild to moderate myopia, hyperopia, and astigmatism. All the contraindications are very similar. The advantages to LASIK versus PRK is that this is a much quicker recovery, less pain. I worked for a refractive surgeon prior to medical school. We had our laser suite in office, and it was amazing to watch someone look out the window, not be able to see the Wendy's sign across the street, lay down, get LASIK, sit up, and see, so well. And that only improves after, getting rid of some of that inflammation. Disadvantages. So creation of the flap can weaken the cornea. You're severing some of the corneal nerves, and that can increase dry eye, so it's something to be aware of. There's always a risk of flap dislocation and a risk of ectasia. Last one we're talking about is SMILE, small incisional lenticular extraction. So with this, you're creating a corneal lenticule using a femtosecond laser, which is then extracted through a small incision normally made by the same femtosecond. I should say with the use of a femtosecond. Indications. So this is from the FDA approval. It's always changing. Every new machine comes out with new numbers, but you're going from a -1 to a -10, and you can treat astigmatism up to -3. Contraindications are similar to LASIK and PRK, but the advantages to a SMILE is that you're not severing corneal nerves like you are in LASIK. So someone with dry eye, pre-existing dry eye that really bothers them, you might look into doing this more than a LASIK because you are hopefully preventing progression of their dry eye. You're also not creating a flap. So for people who are in contact sports or younger patients who, get rowdy, I don't know what they're doing, but you're not creating a flap, so you don't run the risk of flap dislocation, which is painful and kind of the worst thing that could happen if you're a refractive surgeon. You don't want someone coming in with that. And then you're also able to treat patients with a little bit higher refractive error because you're making such a precise lenticule. Disadvantage, some people, there's been mixed studies. like early, right after they have increase in dry eye, that normally goes away. And then obviously always the risk of ectasia whenever you're thinning the cornea, so something to constantly be aware of. And that is all for me. Any questions?
So I'm actually from the era of Arte.
Okay.
And, you know, Arte was actually started in Japan by some, I think his name was Sato. I don't know why I remember this. But it was in 1930s or 1940s, but the instrumentation was so rough, he basically blinded everybody he did. And then it was picked up in the Soviet Union by Fyodorov, you probably heard his name. And the reason they did it there is because, you know, they were communists, so that means you couldn't get glasses anywhere, all these minus 11 walking around and seeing anything. They had to come up with some system. An interesting fact, Fyodorov ran for president in the Soviet Union, and his helicopter fell out of the sky, and he died. I think he was running against Putin when Putin was running the very first time. So don't ever run for president against Putin. You'll fall out of like a first-story window after you've been shot yourself 5 times in the head.
Somehow the helicopter goes down, right?
Yeah, he was killed in a helicopter crash, a mysterious helicopter crash.
Exactly.
He was no longer running for president. Okay, thank you very much. Unless there's any other questions.
How do you know all these facts?
I have no idea.
Get this stuff, Leo.
I have no idea. Okay. Well, because I'm old. Omar, you're next. Omar Saeed.
And Steve Ashton, University, help me out a little bit.
Oh, absolutely. More the merrier.
He's just going to go ahead and get started off, and then I'll pick up.
Just introduce yourselves.
Of course, yes. So my name is Silvash, and I'm a first-year osteopathic medical student at Michigan State University, and I had the pleasure of working with Dr. Omar in preparing this presentation.
And my name is Omar Saeed. I'm a PGY4 ophthalmology resident going into retina next year at University of Chicago.
Great. Okay, so is that all right? Okay, so I will just give you a little bit of background, talk about the benefit of tyrosine kinase inhibitors, and Dr. Omar will delve deeper into drug delivery platforms and recent clinical trials. All right, so starting from the why, as you all know, vascular retinal diseases like diabetic retinopathy and diabetic macular edema, these are major causes of vision loss, and like any other diabetic complications, they are rising year over year. So as of today, the standard of treatment is anti-VEGF, and even though they are incredible drugs, they are far from ideal. And the main problem with anti-VEGF is that they require frequent injections. And this can be hard on the patient, and this can also be hard on the healthcare system. So repeated injection, the frequent injection can cause trauma to the eye, to the lens, to the retina, mechanical tear. And more important than that, these frequent visits by the patients can be an adherence issue. So it's reported to 30% of the patients stop the treatment by their own. So real-world outcomes seem to be often lower than what clinical trial shows. So the question is there an alternative? Is there a better solution that is more sustainable, patient-friendly, and yes, all right. So tyrosine kinase inhibitors seem to be the answer. In combination with anti-VEGF or standalone. All right, so just a little bit of basics about tyrosine kinase inhibitors. These are small molecules. They can cross cell membrane, and they can inhibit angiogenic pathways from inside the cell, like VEGF receptors, such as the same way that anti-VEGF does. But it can also inhibit other pathways, like platelet-derived growth factor and fibroblast growth factor. One thing to note that these drugs have been used in oncology, like axitinib, it had been used in oncology. We're just repurposing them to inhibit the same pathways in the retina. And the goal is to have a more comprehensive control over neovascularization, And they have another advantage, which is that they can be administered in many different routes. And Dr. Omar will speak about it more.
Yeah. Great talk. Good job. So I just wanted to make one thing clear. I think the most important thing is to compare this with anti-VEGF therapy. And anti-VEGF, as we know, blocks the vascular endothelial growth factor. And this is on the extracellular side of the blood vessel. So VEGF is just the only thing it blocks, right? You see there's multiple other things here, but it's just VEGF, and in particular VEGF-A, right? So VEGF-A is only what's blocked here. With the tyrosine kinase inhibitors that we see down here, you block VEGF-A, B, C, and also D, and then you also block platelet-derived growth, PDGFR, and FGFR. These are more like antifibrotic activities. And this is on the intracellular side of it. So it really provides you a diverse arsenal of fighting, this pathology. Some people are also advocating the use of both TKIs and anti-VEGF, since they act on different sides of the blood vessel to work with, blocking neovascularization. So talking about drug delivery platforms. So what are tyrosine kinase inhibitors? Tyrosine kinase inhibitors can be delivered intravitreally like we're all used to. They can be delivered even suprachoroidally, which is more of a newer method of delivery. Periocular. So what does that mean? That's actually an injection, like a subtenon Kenalog injection that we do all the time, or even an eyelid injection. A topical treatment, so that's an eye drop, right? And then some studies are actually going through the oral version or the oral studies of it. So it's very neat. It's very exciting. There's so many different ways. We don't have to always necessarily give an injection because a lot of our patients don't necessarily like that, right? So like we just talked about, all the different types, there's a clinical trial for every one of these at different stages. There's so much that would be a whole lecture in itself to go over. Different stages, phase 1, phase 1B, phase 2, phase 3, all showing different promise. It's very exciting. We'll briefly touch about clinical trials. Like I said, it's going to be a long lecture if we do, but I really want to highlight one of them, which is Apaxili. It's an intravitreal injection, and it's supposed to be delivered every 9 months according to their phase 1B trials. So their phase 1B, so I think the most important here is they compared it with Eylea or aflibercept 2 milligrams. And I think whenever you're looking at any of these retina studies, it's very important to look at the placebo group. What did the initial group, the comparative trial, get? Because it's not always an even distribution. But I think this study did a pretty good job. Eylea, 3 injections of Eylea every 8 weeks, starting out for both groups, and then the Apaxili group kind of got the Apaxili at the end of the 3 injections and then went on their own. And they compared it to the Eylea group to see if they needed any rescue injections for the 1 year that they were studying. They found initially, an 89% reduction in treatment burden. So at 6 months, there was a 73% reduction, and then at 12 months, I think it went down a little bit to 60%. But overall, it was a 90% reduction in treatment burden, which is really exciting comparing to Eylea. And then you can see there's a phase 2 trial that was working with DME. This one was working with more like a wet AMD. And then there's a phase 3 trial also working currently in the works. There is a really cool, another exciting drug that we talked about, the topical version. The topical version is a drug. The study wasn't great, so we compare it with that. We take that into consideration, but it's really exciting so that it's topical. It was just a 12-week study that compared, the 1 drop a day versus aflibercept or Eylea, and it did show a 79% reduction in rescue treatment burden. All right, so discussion, pharmacokinetics, TKIs, rapid vitreous clearance. So, it's a small molecule, it gets taken out easily. You have to have it in a sustained released package. There's different methods of doing that. There can be an implant. I didn't talk about the implant, but there's actually an implant that people put in the eye that delivers continuous drug delivery model. Suprachoroidal, like we talked about, biodepots, all that good stuff. Safety and efficacy, as you know, this is a huge topic. In the oncology world, TKIs are known to have some side effects. You might have learned about that in medical school. But with the ocular versions, these are significantly less concentrated, about 100 times less concentrated than when we use for oncology systemically. So there's no serious adverse effects noted in early retinal trials. 43 to 57%, on average, every study is a little bit different, but remained rescue-free. So that means no anti-VEGF given other than the initial drug, TKI drug. And anatomical gains often outpaced visual improvement, which means the central, the CST values were showing a little bit better versus the visual acuity in the beginning. Conclusion, it's evolved mean treatment paradigm. TKIs act intracellularly, like we talked about. The anti-VEGFs are on the extracellular side. It's a broad inhibition. It blocks multiple different things, so it's kind of just like a catch-all. That's what makes it, this hopefully maybe this miracle drug we're also been searching for. Patient-centered benefits. There's multiple delivery models. You can do biannual dosing, right? And that'd be greater than every 4 weeks. Less frequent treatment, better adherence, real-world impact, future outlook. TKIs could be delivered with anti-VEGF, or they could be delivered on their own. May be essential to comprehensive retinal care. And that is our talk. Thank you very much for listening.
This is actually very exciting. I've been reading about this. It's a whole different pathway because it's intracellular. Because right now they're all biologics, and we have MABs and CEPs, aflibercept, and the MABs like bevacizumab or ranibizumab. But these NIBs, I think that's what they call them, NIBs, these TKIs, is very exciting. And it's nice that you could use them together because they work through two separate pathway systems. So, and it's even nicer if you don't have to keep on injecting them, but it'll put you out of business.
Unfortunate,
You're going into
but
because the optometrist will be treating
Even
them
the-
topically.
Yep,
But it'll be
you're not wrong.
much, much better for the patient.
much better for the patients.
Exactly. Okay,
Where are you
great.
doing your retina fellowship?
University of Chicago. Thank you.
Okay, is there a Peter Maduka? Oh, Peter Maduka, he's on my list as number 3.
I think his flight might have got moved. Yeah. A bit early.
Okay, so he will probably not be here. Okay, is he a resident?
Yeah, he is.
Okay, all right. Stefano,
Yes,
can you
I'm ready
finish
to
up
go.
here?
And maybe if I can take a little bit of Peter's time, is that appropriate, or
You know what?
if I could take 2-3 minutes of Peter's time?
Oh, yeah, sure.
Perfect.
Unless that's him. Are you Peter Maduka? No. Okay.
All right. Buongiorno. My name is Stefano Cena, and I'm a first-year medical student at Rocky Vista University in southern Utah. Today, I wanted to talk a little bit about selumetinib in treating optic pathway gliomas. And before I get started on my presentation, I'm just curious, by the show of hand, how many of you here have heard of or have had some form of experience with optic pathway gliomas? Okay, so that's a lot more hands than I usually get in talking about this in other presentations. My goal today is to be able to explain the relevance in pharmaceutical treatments for chemotherapy and other agents, and also provide you with some good quality imaging for specific optic pathway gliomas. So optic pathway gliomas and specifically low-grade gliomas comprise about 45%, if not half, of all of the brain tumors in pediatric populations. So they're not uncommon. And about 40% of the low-grade gliomas involve the optic pathway in one way or the other. So this is a very relevant. This is very relevant in the ophthalmic community because most of the time ophthalmologists are the first ones to notice a deficit in visual acuity, etc., that eventually leads to the discovery of a brain tumor. It can also manifest in other areas. It can manifest either on either side of the cerebellum and also hemispheres, brainstem, etc. So the standard of care for optic pathway gliomas currently is a mixture of carboplatin and vincristine, sometimes coupled with radiation. So just picture the burden on the pediatric population when you are using IV chemotherapy and radiation to treat this type of cancers. Not only that, but the prerequisite for chemotherapy treatment is anesthesia and surgery in order to receive a chemoport implantation. So on a child that is 3 to 5 years old getting this diagnosis and having to undergo a surgery prior to even starting treatment can be very traumatizing, and it can also have a negative impact on the family as well. So overall, you're looking at about an 86% 5-year overall survival, which is pretty good. And then only about 45% will have a 5-year event-free survival where they don't have any progression on their tumor. So this created an opportunity for alternative treatments for optic pathway gliomas. And that's where selumetinib stepped in. Unlike standard of care for optic pathway gliomas, we're always targeting the MAPK pathway when we're dealing with low-grade gliomas that involve also the hypothalamic or optic pathway in the brain. But selumetinib, targeting being a MEK1 and MEK2 inhibitor, is actually an oral chemotherapy agent. So picture the news you could give your patients if they are going to undergo chemotherapy treatment, that their alternative from surgery and chemoport implantation, weekly IV infusions, potentially radiation, and then you present them with an oral agent, 1 pill a day. It's a game changer for pediatric populations. So the Pediatric Brain Tumor Consortium decided to really throw themselves in the investigation of selumetinib as a potential candidate to replace chemotherapy standard of care. So the study that I wanted to mention to you is 029B, and they looked at hypothalamic and optic pathway glioma individuals with or without NF1. And all of us here know what NF1 is, but I wanted to provide some good quality pictures that were provided to me from a friend at Mayo Clinic, colleague of Dr. Skorin. And right here, I wanted to show you on the optic pathway NF1, he called the bubble braid look when you're looking at those MRIs. This is a very classic case of the NF1, and when radiologists see this, first thing they do is they call one of you to be able to discuss next steps for this type of patients. So the study included individuals ages 3 to 21. So whether or not you would be a pediatric ophthalmologist, chances are if you have a patient towards the later ages, you will still be able to provide some type of care, even for ophthalmologists that are not pediatric focused. The results for the clinical trial were very promising. The toxicities were assessed as per the CTCAE version 4 at the time, and a grade 3 toxicity was towards the higher end that it was recorded. Even though the sample population was very small, I recognize they had 25 of these children for the phase 2 clinical trial. As you can tell, the progression was, the tumor resected very well, and nearly all of the individuals, with the exception of one, had very good outcomes with the use of selumetinib compared to standard of care. Progression-free survival was 78% at 2 years. We don't have a 5-year because this is a very new clinical trial, and they're currently on the phase 3 clinical trial. And then the visual outcomes were stable in 74%, and they saw improvement in 26% of the participants. So how do you recognize a optic pathway glioma in your clinic if you have a patient that comes in pediatric or not pediatric? Most often, they present with loss of visual acuity, and it's going to be most likely unilateral. That is the number one sign. Some of them will have proptosis, which tends to be a sign that the tumor has moved very close to the eye along the optic pathway. And the confirmation is done via OCT and MRI. I will touch very briefly on OCT, and we're very, very fortunate to hear from Dr. Davis' lecture later today, where he will discuss a lot more than I can tell you about OCTs. But this is the two next steps for diagnosing and ruling out an optic pathway glioma would be OCT and MRI. Right here in the MRI, you can observe the glioma growing along the pathway, optic pathway. So what I hope that you're able to get out of this is, even though selumetinib is currently undergoing investigational treatment and they're under phase 3 clinical trial, clinical trials are something that we often hear about, oh, they did this clinical trial in the past and it's been very good, etc. But you can utilize, as physicians, clinical trials currently in your practice. So I put together a QR code that I hope that if you can take a picture, put it somewhere in the back of your mind, and if you ever encounter a patient that has an optic pathway glioma, especially a pediatric patient, this QR code will take you to a database that will show you the nearest site to your clinic that will offer the clinical trial for that patient. It's such a devastating news to receive, to tell a family that they have a brain tumor, that the children has a brain tumor, right? But picture the good news you could give together with that there are treatments currently available where all that they can take is just one medication orally. Not only that, but sometimes chemotherapy treatment can be very expensive for the family. And if they participate and they qualify for the clinical trial, the treatment will be completely free of cost. If the site is within a certain radius, the Pediatric Brain Tumor Consortium and the COG group, the Children Oncology Group, will actually reimburse the family to come and receive their medication. And they only have to meet once a month. They give them all the medications for the entire month, and then they just assess toxicities. And they work very closely with the ophthalmology team. So another additional benefit to you as the physician is that if you're unsure about whether what you're looking at is an early stage of optic pathway glioma or not, you can also send your information to them, and you will have the optic pathway glioma world experts looking at this information and giving you a second opinion for free. So I really hope that if you can get something out of this presentation is to utilize the current clinical trials as a potential offer to your patients when they have diagnosis that currently we don't have many options available for them. And that's my presentation. Thank you so much.
I have one. So you had one of those, the 25 just really didn't respond at all. Do you know if they had, did the child just pass away, or were they able to go and get standard treatment then, with the routine treatment? Do you know what happened to that one that did not respond?
Yeah, so the one that didn't have any response and had to eventually drop out was specifically non-compliance from the protocol. So if the family is not adhering to the protocol, they're not coming back, not doing the follow-up visits, that data will skew everything. So when there's non-compliance, they just have to drop them from the study. And there are certain points before they get there, but unfortunately, this specific patient was non-compliant.
So I'm assuming that they probably didn't, because the standard therapy is much more complex than, the oral, so they, okay, thank you.
Correct.
All right, thank you very much. And Carson Claveau. You're Carson Claveau? I'm sorry? I'm not Carson, but just in case, okay, well, there is another one more then. Okay, so is he also a resident? Okay. And then Daniel Porter? Did you give your presentation to them back then?
All right, well, good morning, everyone. My name is Daniel Corder. I'm a student doctor at Liberty University College of Osteopathic Medicine in Central Virginia. I'm going into my 4th year. Today I'm going to be talking about an exciting new innovation in retinitis pigmentosa treatment. I think it should be just as exciting as keeping up with the Kardashians. So I have no conflicts of interest to disclose today. So for me, I wanted to talk about this because I was on my psychiatry rotation this past year, and my preceptor gave me an old newspaper, Psychiatry News, and told me to look up an article and find something interesting to be ready to present. And so I read this title, Could Light Energy Be the Next Wave of Neuromodulation? So that kind of caught my eye. And it was talking about optogenetics theory, which is basically using light-sensitive opsin proteins to directly control individual neurons. And so the theory was that in the future, if you could inject these neurons with the opsin proteins and then specifically fire those neurons, you could have a very refined way to treat psychiatric disorders. But me being an having ophthalmology interest, I also noticed that they referenced this company called Nanoscope Therapeutics that was using a similar technology to try to treat retinitis pigmentosa. And so I wanted to find out more about, what this company was doing. But first, just to quickly review retinitis pigmentosa. It's a group of inherited retinal dystrophies marked by photoreceptor apoptosis and degeneration of the retinal pigment epithelium, resulting in progressive vision loss. And so there have been up to 200 different mutations identified in lots of different proteins, and each of those proteins sometimes can have multiple different mutations. And it can present very differently, but it's usually onset at a young age, and there's usually initially nyctalopia and progressive loss of visual acuity, which could be peripheral or central, until you have complete visual loss. And fundoscopy is going to show potentially an optic nerve with a waxy pallor, attenuated retinal vessels, and bone spicule splotches of intraneural retinal pigment. And as we all know, management for this is really just supportive. There is no definitive treatment for retinitis pigmentosa, but there is a lot of research going on and a lot of clinical trials in industry to try to find that definitive treatment. So I wanted to review what is going on. What are the general approaches to treating retinitis pigmentosa in terms of innovation? So I read a review article. It reported that there were 131 drugs in all stages of clinical trials back in 2022. 6 of them were in phase 3. And 50% of these therapies were cell and gene therapies. Now, there are other types of therapies like small molecules, oligonucleotides, immune globulins, but 50% were cell and gene therapies. And the general approach with gene therapies is to incorporate non-mutated genes into the surviving photoreceptor cells. So there are 2 mechanisms by which this could happen. The gene could be expressed and create a protein that basically replaces the protein that's deficient due to the mutation, or the gene could be expressed and create proteins that interfere with disease pathways like apoptosis, getting to the underlying etiology. However, there are a diverse set of target proteins that you could try to attack. Some of the most common ones are rhodopsin, usherin, and retinitis pigmentosa GTP regulator. But the problem with this is that there are so many different mutations and so many proteins you could target. With each therapy, you're not really going to be able to cover a broad range patient population since there's so many different mutations that could be causing a patient's disease. As for cell therapies, there are also 2 kind of methods by which this therapy could work. You transplant cells that release neuroprotective factors to basically help promote the survival of the surviving photoreceptor cells, or this transplanted cells actually replace the damaged and dying cells. Now, with the first method, you can sort of surmise that as the disease progresses, there are less and less photoreceptor cells available, and so any cell therapy that's trying to protect them, it's probably not going to be as effective in late stages. Whereas the replacement method, there's a little more optimism that it could be used in late stages. But this is where we come to Nanoscope Therapeutics, that company I read about in that Psychiatry News article. So they're a company that is designing a specific opsin protein and injecting it into the bipolar cells of the retina using an adenovirus. And so the goal here is for the gene, this is a gene being expressed through a plasmid in a bipolar cell, to basically promote the bipolar cell to become the photoreceptor cell. And this is just a diagram showing it's an intravitreal injection. The adenovirus has cell markers that allow it to endocytose into the bipolar cell, and then the bipolar cell starts expressing the gene, creating the protein that is light sensitive. And we can see that this is advantageous because it's independent of any mutated genes causing it, and it's also not dependent on surviving photoreceptor cells, so it could potentially be used in later disease stages. So their specific protein or gene that they're developing is called synthopsin, and it actually consists of 3 different light-sensitive opsin proteins. One is sensitive to blue light, one is sensitive to green, and one is sensitive to red. And along with an ion channel that helps induce depolarization when light sensitizes the cell. So because it has red, green, and blue, it's actually very useful for responding to just ambient light. When you're just focused on one opsin protein, it has to be a very specific wavelength of light that actually stimulates the cell. So their trials have been showing that their protein, when expressed in bipolar cells, is very responsive to just ambient light. And you can see here, this is a diagram of what it looks like. The blue represents what responds to blue light, and that's also the calcium channel. And then there's a red ligand and a green expressor responding to those wavelengths of light. So they actually just completed a phase 2b clinical trial called RESTORE. And they tested this on patients with severe retinitis pigmentosa and showed improvement in visual acuity, shape discrimination, and just mobility, day-to-day activity mobility through a 52-week study period. And this was just announced in March of this year. So in summary, this is a promising therapy showing clinically meaningful improvement in visual acuity, even in severe retinitis pigmentosa. And this company has received FDA Fast Track designation, so they're really trying to help them get through the drug approval process as rapidly and efficiently as possible. There's a lot of optimism, and they're planning on submitting a biologics license application this year, as well as beginning phase 3 clinical trials. And so I thought this was a very interesting piece of news to talk about, because for so long retinitis pigmentosa hasn't had a definitive treatment, and now it really seems that in our career, in the upcoming years, our careers, that there really could be a true treatment to help patients with mild, moderate, and severe retinitis pigmentosa. So here are my references, and are there any questions?
This is sort of fascinating stuff, you know? It's, because our patients with retinitis pigmentosa, it's very devastating with how much you can do for that. But there's one more thing I'd like to point out for all the medical students that are here. Did you notice what he did? He was on psychiatry rotation and found an eye thing to talk about. On every single rotation, you should be able to find an eye situation that you could, basically capitalize on. Maybe not orthopedics. There's no bones in the eye. So, but any other rotation. Okay, thank you very much. And I guess we have a bonus presenter. Must be you. There's nobody else. Do they have all the information they need? I don't know who you are, so you want to make sure you introduce yourself and everything, okay?
Hey everybody, good morning, and I guess I'm the last second fill-in. So I'm a medical student, I'm a third-year medical student at Nova Southeastern, and I am excited to present to you guys our tool for using AI to help diagnose anterior segment diseases. And this is our financial disclosures. So our story kind of began with an attempt to identify cancers on the ocular surface. Sometimes they're obvious, as you can see with lesion on the left, and sometimes they're not so obvious with the lesion on the right. And furthermore, pterygia are very common in the South and where I am in South Florida. And as many of you know, up to 10% of patients with pterygia may harbor cancerous lesions. So it's important to be able to detect this as opposed to telling patients just to observe. But sometimes it's not so easy to identify. So on the left, if we look at the small kind of fibrotic change around the 7 o'clock position, it may look benign, but in this patient's case, it was actually cancer. But in the case on the right, this more of like hazy diffuse opacity actually was just a benign pterygium. As some of you know, OCT has become a valuable tool for the diagnosis of OSSN. But the problem is that not everybody may be trained to interpret, so we decided to develop an algorithm that had about a 90% accuracy in detecting OSSN versus pterygium. And what the results of this project showed us was that AI actually has an excellent diagnostic accuracy and outperformed expert clinicians actually in categorizing the lesion from OCT images. So we were thrilled with our results, but the issue is that not everybody has an OCT in their office. So we decided to develop an AI algorithm to interpret from slit lamp photos as well. And we got good results there as well. Our algorithm also outperformed expert clinicians in diagnosing OSSN. So when we looked at the landscape, we realized that there is a supply and demand mismatch for eye specialists, and it's only expected to continue growing in the coming years. Vision is an essential part of everybody's life, and at some point, if you live long enough, you're probably going to get a cataract. 1 billion people around the world have preventable vision impairment, of which cataracts is probably the leading cause. And the eye is a pretty confusing place to be, especially for non-specialists. It's a complex organ that unfortunately is not a very big focus in medical education, and most non-ophthalmologists don't really have equipment or training in their offices to diagnose even common eye conditions. So to return to the question we asked ourselves, how can AI help integrate into a clinical workflow and become a part of the solution? So our solution is an autonomous screening software powered by AI that is platform agnostic to detect diseases of the front of the eye for non-specialists. And so far, we've developed a cataract screening tool that has an accuracy of about 94%. And here's some data for our cataract model. Here's some data for our cataract model and its performance. And ultimately, the model works well, but integrating an AI solution into a clinical workflow is more than just deploying a model. One of the things that we realized is we get very clean, perfect data for our research, and then you try to deploy it and test it in like a clinical setting, and the data's not so clean. You give a portable slit lamp, for example, to somebody, a medical student like me, and I try to go take a photo, and it's not so clean. I haven't really taken portable slit lamp photos before before this whole project. So if you want to facilitate a screening and targeted referrals across the healthcare continuum, we kind of realized that we need to find a way to build in a performative feedback system. So our technology, so just to give you a little overview of our technology, say a patient walks into primary care or an urgent care for screening, an image can be taken on a portable hardware tool, and there's a couple out there that are in the market. Remedial is probably is the biggest one. And our solution is the software that ultimately does the quality assessment and then spits out a diagnostic or a screening recommendation based on the image in real time. So the idea is to basically try to turn this into a medical school in 2 seconds. So we've looked at ocular surface cancers and cataracts, and we're currently exploring other pathologies like dry eye disease, infections, and others. And ultimately, the goal is to create a platform that can help facilitate screening at the anterior segment. So we actually did a little bit of surveying for physicians, and these are all primary care provider surveys. It wasn't specialists. And just to get an idea for the feedback from physicians about their interest in using AI in their clinical workflows and whether there's any value or whether they feel comfortable. And we got generally positive results from people about the idea of using AI in a clinical workflow. So we envisioned trying to create a platform that could be ported onto or put onto different portable hardware companies. And we're trying to create an intelligent interface to help empower generalists in the primary care settings. And our goal is to ultimately try to create targeted referrals into an ophthalmology setting, rather than everybody just being sent to an ophthalmologist for something that could be potentially triaged a little further upstream. So I guess some take-home points. We're trying to support early detection of anterior segment diseases, and we're hoping to create targeted referrals. And ultimately, outside of like places in the U.S., we also want to try to address gaps in underserved or remote regions. This is it's agnostic to location. If you can create a cloud-based solution and upload things to a cloud, there's obviously privacy and HIPAA concerns and whatnot. But in theory, this could be used to help screening in remote areas like villages in India, where, for example, cataract detection is a little bit more of an issue. And this is the team, and thank you very much.
Great talk. I really love to see that, especially like it's very obvious how that can be very applicable in a remote or rural setting, especially like places in like rural southern New Mexico where we have a lot of like farming communities and things like that. What I'm curious about is when you generate those rock plots, you have some comparison method that you're looking for that said that these patients in fact had cataracts. I missed it. What was the reference method that you're comparing it to? Was it previous diagnoses, and how were they made?
So the data was pre-labeled. So we have data that's been labeled by ophthalmologists and specialists at either Bascom Palmer and other institutions. So it's been screened by, I believe the stuff that we've used from Bascom has 2 specialists and then 1 adjudicator for at least the cataract data.
Okay.
But yeah.
Any other questions? Okay. Well, thank you very much.
Thank
Thanks
you.
for filling in,
Yeah.
too. So, everybody, go to breakfast, I guess. And then be back at